This meeting is now being recorded. All guests have been muted. All guests have been unmuted.
Testing, 1, 2, 3, testing. Should I ask if people can hear it? Can you hear me? I don't hear anything.
Well, we can hear you.
Okay, thanks.
All guests have been muted.
So I don't need to unmute it.
Not right now.
I don't need to. Today's webinar is the second in a series titled Reducing Racial Disparities in the Treatment of Depression. Our topic for today is shared decision making and depression treatment in primary care. We have 3 subject matter experts with us in today's webinar, Vicki Olson, Program Manager for Stratus Health, and Dr. Art Weinman and Tasha Gastany from Health Partners in Park Nicollet. My name is Kwana Walker, and I'm a Manager in Behavioral Health at Health Partners. I will be moderating today's webinar on behalf of the Minnesota Health Plan Collaborative, working to reduce disparities and improve antidepressant medication management. We will have time for questions following the presentation. There's a couple of logistical slides that we'll go through really quickly. The first thing is to call your attention to the Stratus Health website. We have a provider toolkit, and that is focused towards primary care providers or other kinds of providers, and it's with the goal of helping them to have some tools for managing medication and antidepressant adherence. The educational objectives for today. Following this learning activity, participants will be able to discuss what shared decision-making is in at least two of its components, describe how shared decision-making can be used for depression treatment in primary care, explain how to incorporate shared decision-making into depression treatment in primary care, and people can get CEUs for this. So we'll have some instructions at the end about that. And we have our disclosure policy, our content validation policy, and note about commercial support. And again, the faculty today are listed here, and the planning committee includes Patty Graham, quality consultant at Health Partners, Marcio Tipka, quality consultant at Health Partners, Sharon Kopp-Huth from the Park Nicollet Institute, and Kwan Walker, LICSW. And again, we work with the Health Plan Collaborative together on this project. So with that, I want to introduce Vicki Olson from Stratus Health to talk about shared decision making.
Hello, everyone. I'm happy to be here, and it's a topic that is kind of near and dear to my heart, so I commend you on working on this topic. The objectives for my very short, brief overview is to define shared decision-making, review the SHARE approach. So SHARE is an acronym used by the Agency for Healthcare Research and Quality. They've developed a toolkit, Train the Trainer toolkit on shared decision-making, and we are currently in the process of doing some national training. So you'll notice some of my slides have a different background, and those are actually slides that you can get on the AHRQ website. So these are all publicly available, the ones that have the HRQ background to it. And then I wanted to share a couple websites that will summarize, be kind of good resources for you for shared decision making. So our Train the Trainer workshop is a full-day workshop, so I'm going to do this in 15 minutes, so obviously it's a very quick overview. So I want to spend a little time on definition, because I do think people struggle with what shared decision-making is and what it isn't. So shared decision-making occurs when a healthcare provider and patient work together, so there is a partnership. You need that interaction between a professional. It could be a physician, nurse practitioner. It could be a pharmacist. It could be a nurse expert. It could be a social worker. So it depends on the topic and how people have organized that to make a healthcare decision. So it needs to be a situation where there is actually a decision to be made. So when people talk about patient education, patient education isn't per se shared decision making. Doing the choosing wisely utilization, it may in an encounter impact utilization, but that's not the purpose of it. And the optimal decision takes into account evidence-based information. So it's still important and very important to reinforce with providers that this is evidence-based practice. So if there is a clear evidence-based solution, that may not be the situation for shared decision-making. But oftentimes that's not the case. So evidence-based practice is still very important to help the patient understand what the options are. The provider's knowledge and experience is also important to bring to bear in the situation. And then, of course, the patient values and preferences is really what we're trying to highlight as an addition into the decision-making process. So why is it important? In many cases, it isn't clear, and so when you hear the terminology preference-sensitive conditions, those are conditions that have been identified as where there might be multiple options, including doing nothing that is really evidence-based and helping patients understand when those situations occur and what the options are is important. So patients may not know that there is more than one treatment option and that one is not clearly superior to the other. So having that discussion can help the patient understand the options and then clarify their own values and preferences. So why do shared decision-making? What benefits are there? And the two that have been shown by research really is the patient experience of care, of course, with value-based purchasing and value modifier. Certainly organizations have some incentives for patient experience of care besides just being the right thing to reinforce with the patient. And then the other piece that's been shown through the literature is adherence to treatment plans, which makes sense. If you're involved in the decision, you understand, you've picked a decision that fits with your values and preferences, it would seem to follow that then you would be more compliant with that. And so therefore, can help improve health outcomes. When not every encounter is there a decision to be made needs a treatment decision. So it really needs to be that particular situation that arises, although it arises probably more frequently than many realize in the course of getting health care. And the other piece that they really reinforce in the SHARE training is that it depends on the patient in terms of how they want to be involved. So a patient who really does want to defer to the physician or provider's experience and expertise, that's okay too. But the idea is that they have that option and the continuum might be from one end to the other in terms of how that patient wants to be involved. And of course, not making a decision is also making a decision. So McCool and Clayman did a review of the literature, and so these are 9 different criteria that came up no matter what shared decision-making framework, and there are several of them out there. These were 9 consistent traits of shared decision-making. So these are kind of good ones to when people think they're doing it, but they're not really doing it, or they want to be reinforced as to, is this meeting the criteria of shared decision-making? This is kind of a good checklist to look at. Are you doing all of these pieces? The SHARE approach did a lot of review of from experts and review of the literature in terms of defining the toolbox. And at the same time they were doing this, we were actually doing it in Minnesota for the Minnesota Shared Decision-Making Collaborative. And I was very pleased, I guess, of how reinforcing it was from our work too. So just a few things that I'll just point out. That first step is really important. In fact, in Palo Alto, they identified, patients feel very vulnerable when they're in provider situations, so that permission giving and seeking that your patient's participation is a very important first step so that they understand that they can participate in the decision-making and what the expectations are, particularly if there's some differences in practice as that changes. And then step 2, exploring and comparing treatment options, is where you'll see decision aids used frequently. So decision aids are not just shared decision-making, as you well know, but decision aids can be very helpful, particularly for providing some of that risk and benefit and option information and helping the conversation, guide the conversation to what might fit best for them. And then the values and preferences is obviously where you're trying to have a conversation more about what is important to them, reaching a decision and then evaluating it. So this is actually a handout. You can download this from the ARC site. It goes through it's an overview of the shared decision-making. This is tool 1. There's actually 9 of these, so I'm not going through all of them. but these are kind of, they're good handouts and very reinforcing of a lot of the information. And benefits of using decision aids, there is literature really to support that work in addition, because it does improve the patient's knowledge of what their options are and have them have more accurate expectations of what the risks and benefits are. And then obviously being more informed leads them to make decisions that where they're both more participatory and also more consistent with what their values are. So in the shared training, we do quite a bit of work on having the conversation, and for those of you who are familiar with the ICSE conversation model tool, obviously there needs to be more information on how to help them understand. So a big focus on health literacy, health numeracy, teaching back and making sure that they understand and having the cultural awareness. So it fits in obviously with your focus on diversity. And but it is a skill set, you know, of being able to have that conversation. So there's ways in more education and curriculum to help you if you're so interested. Tool 2 goes through the 5 share steps, but it gives scripting. So I find it helpful for people to have something really concrete as a starter of what would look different if I was to initiate this conversation in each of these steps. So they're not meant to be prescriptive, but to get conversations going. And then, of course, you know, when providers see scripting, they can kind of do some thinking about what fits the best for their style and practice and conversation. So here's a couple resources. This is the SHARE approach on the ARC site. And then, of course, on the Ottawa site, you'll see a toolkit on shared decision making. We do have a website, and we focused our website for Minnesota Shared Decision Making Collaborative very much on implementation because we found that's where people were at in terms of a struggle. So you'll see lists of resources and really how to get it going in an organization. And then because you were focused on depression, I just thought I'd give you the link to the Mayo Depression Decision Aid. A lot of the decision aids are organized by topic area or by question if you're using the option grids. And so when you hear providers say, oh, I don't have enough time to do this, some of the decision aids can be really helpful because in a way they help frame the conversation and make it more efficient so the patient can pick. This is most important to me and might make the decision after, you know, going through a couple of the questions. And so that can help kind of frame the conversation. And here's my resource information if you have any questions.
Thank you, Vicki. We're now going to switch over to Art Wyman and Tasha Gastany.
Thank you, Quan. There. I'm Art Wyman. I'm from the Family Medicine Department on the Health Partners side of our medical group. I'm one of our regional medical directors in the primary care division. And I'm here with my partner, Tasha Gastany, who is from the Department of Family Medicine on the Park Nicollet side, and she also is a regional medical director. And in those roles, part of what we do is each of us has primary responsibility for behavioral health initiatives and for improving care for behavioral health problems, including depression, in our respective divisions. And that's important. You know, it's interesting, just a few years ago, she and I were competitors. And fortunately now we're partners, which allows us to support each other and to learn from each other. When this slide talks about successful outcomes start with a stable foundation, if you look at the absolute bottom, part of it is our medical groups are working together, and we have been able to learn from each other. But it's not just primary care divisions that need to come together. What we have found is that to have effective care for depression, we also need to work with our behavioral health colleagues. So we've collaborated with psychiatry and, in fact, moved forward to where we've developed a uniform protocol that's shared between behavioral health and primary care that makes care more consistent and better across the entire medical group. And then finally, we're trying other things, such as actually integrating therapists into the primary care area. Now, in addition to the collaboration, in order to be successful with these outcomes, we need to understand what's going on. And this tangle is the way many of us see depression and depression care, and we need to untangle it if we're going to do better. Part of the better is understanding where some of the problems are. We know many, many patients, as many as 1 out of 6 adults will have major depression at some point during their lifetime. And we know that many patients who are depressed come in and are never diagnosed. Well, first, many don't even come in at all. They don't seek care. And those who do rarely come in saying, gee, doc, I'm depressed. Can you help me with that? Usually we need to tease it out because they present with other complaints. And unfortunately, many of the times they're misdiagnosed. So only 1/3 to 1/2 of patients get the diagnosis. And then once they do, the majority of them don't end up getting all the care or the appropriate care that they need. They often don't fill their prescriptions or make an appointment with a therapist that was recommended at their visit. Or even if they start that, they don't follow up. Or many of them stop taking medicine whenever it runs out. They finish their first month and they'll stop, or they'll go for 3 months and they stop at that point. Partly because, well, gee, I'm feeling better, I don't need it anymore. But often it's because I'm depressed and it's too much work or effort. And part of the difficulty is because we have not involved them in those initial decisions the way we should, they are less likely, as Vicki had said, to follow through with what our recommendations are. It's particularly hard for people who are depressed. Part of our problem that Tasha and I deal with is that although it would be a little more comfortable and maybe easier to send all these patients to a psychiatrist, they're not out there. Often when I talk about depression with groups, I'll say, how many of you in this room take care of patients with depression, see patients with depression in your practice? And virtually every hand goes up. And I say, and how many of you have enough behavioral health resources in your community? And every hand goes down. Like it or not, most depressed patients start in primary care, and the majority of them will receive all of their care for this problem through their primary care clinician. The difficulty is that our ability in primary care to provide excellent care for this varies widely, and part of that is our ability or inability to do shared decision-making and fully engage with patients. So next steps, I'll pass this to Tasha.
Hi, this is Tasha Gustany, and here with everybody, as stated earlier, and working in family practice, the tricky part about what we do is often people don't come in. Sometimes we get lucky, but they often don't come in presenting with depression alone. Depression gets tangled up in chronic disease and chronic pain, and we also deal with the stigma around it, and people don't want to admit that. And so learning to recognize what these signs are when they're tangled in with those other things is important. So we talk a lot about a screening tool that we do that's called the PHQ-9, and the screening tool asks questions that are listed here on your screen: depressed mood, irritability, decreased interest and pleasure in things. Often people come in and say, you know, I get home from work, I used to exercise, I don't feel like doing that anymore, I don't want to hang out with my friends anymore. Weight changes, both gain and loss. Sleep activities, they say, well, I'm feeling depressed because I am not sleeping, and the question then really is are you not sleeping because you're feeling depressed? Activity changes. Fatigue is common. We see fatigue all the time, and more often than not, it's hard to find a reason for the fatigue, such as thyroid disease or anemia or those types of things. People feel guilty and worthless, and they can't concentrate at work, and they start missing work. And then, of course, number 9, which is thoughts of suicide, is a critical piece to make sure that we're always asking these patients about. So I think it's important that if we're thinking about depression with a patient, to screen for that. This is where shared decision-making can definitely come into place, and you know, you need to validate a patient and how they're feeling and say, you know, I understand that you're feeling really tired, and I definitely think we need to check some medical reasons that I may or may not be able to fix, but let's make sure that we don't have any underlying symptoms of sadness, and sometimes using the word depression is just too harsh because of that stigma. So using words like, are you feeling blue, are you feeling sad, those types of things can make that a little bit easier with that patient. So on the next screen, we have the PHQ-9, and we make it a habit to, if there is a diagnosis or on their medication, we screen with the PHQ-9 frequently with these patients, and with Minnesota Community Measures, it's really important that we're doing these in the right intervals. But sometimes if you don't have time, there is the PHQ-2, which is 2 questions. And there's some evidence out there to support that maybe every patient should at a minimum have a PHQ-2 offered. So help identify that. So we have a protocol that has been developed with psychiatry and primary care, and it's built into our electronic medical record. And some of the mistakes that we make in primary care is we'll do a trial of a medication such as Zoloft or fluoxetine or something, but we don't titrate high enough. We get them a little better, but we don't get them to therapeutic levels. So this protocol has helped primary care titrate higher to be more comfortable, or to even add a second medication. Maybe they're on Zoloft, but they're really tired and they need, maybe Wellbutrin would be helpful. And that has helped with that bottleneck into psychiatry. So when this patient, if I refer at 50 milligrams of Zoloft to psychiatry because they're a little bit better but not quite there, and they see psychiatry and psychiatry titrates to 100, that could have been handled in primary care. And again, the shared decision-making gets built in here because it's asking that patient, you know, I know you're feeling better, but are you feeling as good as you want to? And are you willing to consider increasing that dose of medication? And just as important in this piece with the shared decision-making is medications work great, but oftentimes our mood is driven by our thought process, and that's where therapy comes in. Some people want to start with therapy because they don't want to be on medications. They want to start with diet and exercise. That's all wonderful, and it works great. And the important piece there is to make sure you're doing that follow-up. Sometimes I work with patients and I say, well, we could do a month trial on medication and see how it works. I'm not going to make you take it in a month if you don't like it, but maybe if it makes a difference, you've got everything to gain and nothing to lose. Or sometimes I say, let's try the therapy first. Let's see what happens. Let's follow it up in a month and see how you're feeling. So those are opportunities where you're engaging the patient to participate in their care. Here's an example in our electronic medical record of the protocol, and we have the protocol built into it so you can refer to it. If you have questions, we have the note that's built into this. You can see we have the initiation of Wellbutrin as an example in this slide and Zoloft. So it helps make it clear how you titrate those medications. Built into this protocol, we also have instructions about titration, because if you're telling a patient that has depression, you're going to start half a tablet for 1 week, and then in 1 week you're going to increase it to 2. Are they likely going to remember that? So we make sure we put that in our after-visit summary. Plus, we also know that they're aware of the side effects of the medications, because we don't want them to feel like we're giving them something and then they don't have that awareness. So I am going to pass it back to Art so he can review their protocol.
Yeah, and we've been fortunate because Parks started this work back in 2012, and we're starting to catch up to them. But we did the same thing that they did, which was met with our behavioral health folks, and to maybe take a step back from what Tasha said. This is the pathway that we share with all of our clinicians, and frankly, I would sometimes share this with the patient. And we use the PHQ-9 not to make a diagnosis of depression, but to tell us we need to be thinking about it, and to help us list the criteria so we use our own clinical judgment and knowledge to say, yes, they have major depression, or no, they don't. But the PHQ-9 score also helps to decide what are the alternatives that we should be offering to the patient. And the one that's highlighted here, for example, is somebody whose score is 10 to 19 and who we diagnosed with major depression, needs to do a number of different things, or could do a number of different things, but they're not going to do it on their own unless we get them fully engaged. Plus, they've got some decisions to make on what the best approach to care would be. Look at that. This is the key. We need to engage the patient. And frankly, what shared decision-making is meant to do is be one more way to fully engage the patient. We know that patients who are engaged in their care will have better outcomes and a better overall experience. And that's true with depression just as it is with any other medical condition or behavioral health condition that we treat. Now, in depression, it's interesting because we have tended to find that shared decision-making has been depression adopted a little bit more easily in some of the procedurally oriented specialties. If what you're doing is deciding, I'm going to have this surgery or not, or choosing between two different procedures, it's fairly easy to say, here's option A, here's option B, take a look at these materials and tell me what you want to do. Much of non-surgical medical care is much less clear and much more fuzzy. And you would think initially that that would be the case for depression, and it turns out that it's not. Because although depression is challenging to treat, in fact, some of the decisions that need to be made are relatively clear, and that's where you can pull the patient in. And what I'd like to talk about and give you some examples of over the next couple of slides are some of the scripting that I use with patients as we do this, and then talk about some of the choices they have. The classic choice for patients with this diagnosis was, do you want to be on medication or do you want to go see a therapist? And we now have some other options, including some that are online that Tasha will be telling you about. So the first thing for any patient, however depressed they are, is that there are things that they can do for themselves, but unless we engage them and help them make the decision to do that, it won't happen. And actually, I'll take a step back. Vicki had said that education, while important, is not shared decision-making, and that's true. But particularly in depression, if you don't do the education, you can't get good decisions made at all. Part of it is that with particular cohorts of patients, those from certain ethnic or national groups, there are particular stigmas or other misconceptions attached to this. And so the first place that I start with anyone, but particularly for the folks who come in with that mindset, is depression's a disease. It's a disease like high blood pressure or heart disease or diabetes, and just like those, it's not your fault. So you're not a bad person or a weak person because you're feeling depressed. When you get depressed, there are changes in the chemicals in your brain. That's why medication can help. If it was a problem of not being strong enough or being too weak-willed, medications wouldn't make any difference. So the first thing to understand is this is a disease, but there are certain things you can do to help it get better, and you need to be part of making that decision. So I'll take whatever time it takes to get the education. Sometimes it's easy. Sometimes that's the majority of that first visit. We know that for all patients who have depression, there are some things that will help, whether it's mild or more severe. And I'll say this to patients as well. There are things you can do to help yourself totally apart from it. For example, we know that there are chemicals in the brain that will help you feel happier and feel better. They're natural products. They're like some of the drugs that people take to make themselves feel happier, but they're a lot safer, and they're inside you. Some of them are called endorphins. And one of the ways that you can get those chemicals higher in your brain to feel happier is to exercise. Is there an exercise you like to do? And many patients will say yes, many others will say no. Some look at me like I'm crazy. And then I would say, and if there is, if they say yes, I say, are you doing that now? And almost all depressed patients will say no, because part of depression is withdrawing, and it takes more effort just to do normal day-to-day activities. So I will say to them, well, this would help you, and it doesn't take a lot. Just walking 3 or 4 times a week can make a big difference. But you know what the absolute best exercise is to improve your mood? And they'll guess walking or swimming or jogging or something. I'll say, it's a trick question because the answer is the best exercise is whatever one you'll do. If you like to run, that's a great exercise for you. If you don't, and right now I don't because my knees won't let me, it's a bad exercise for you. So is there one that you would like that you think you might want to do? Most of them, unless they're more severely depressed, come up with something. And then, okay, well, let's talk about that. How much are you doing now? And by the time I see you back in a few weeks, what do you think you could change? Okay, is there something you would pick? A lot pick walking. I've had people pick dance, which is really kind of cool because that has other benefits. But by getting them involved in making this specific decision and by helping them to set an action plan that they choose, you can really go further forward with this. I know of one patient who chose as their action plan for exercise that they would drive past the gym and look at it once a day. And I said, that's what you can do? And they said, yes. I said, great, let's do that. And 2 weeks later, they came back and said, I've been looking at it. I think I ought to go in and talk to them. And over time, they built up, and they did. But it wasn't me saying, what are you going to do? It's them helping to make the decision on which way to go. If I say to them, I think you should walk, will you do that? They'll all say yes, and they won't do it. It has to be something that comes as part of their decision-making. Similar to that, that's physical. There's also a social component to this. We know that patients who maintain social contacts with family and friends tend to have improvement in their mood. But again, part of depression is that patients withdraw. And so if a patient has withdrawn, they won't get that benefit, their mood will go down. Similar to exercise, I'll say, are there people you like to spend time with, people that make you feel better about yourself? And often they'll say, one or two, at least, and I'll say, can you tell me who that would be? I'll say, how much time have you spent with them recently? And again, the answer is very often, well, not that much. Again, because that's part of the depression. So we set up an action plan on that. You really like your cousin. Could you and your cousin get together sometime in the next 2 weeks? Would you set that as a goal for yourself? Or is there another person or another way you'd like to get out there? That's why I mentioned dance can be good, because that also gets you out among other people. And again, it's not me telling them what to do, it's them making the decision. But it's nice to get the question out there and to see what they say. First, because if they actually say it, then they're committing to it in their mind. It's more likely to happen. The second is every once in a while you have to say that may not be the best. I really enjoy going out with my buddies and having a 12-pack of beer on Friday night. Well, probably not the best choice for treating your depression, and we would talk about that. And hopefully by then I would already have done my initial screening questions on chemical use in any case. Finally, enjoyable activities. Part of what we do in primary care is we treat a lot of different things, including musculoskeletal problems. And one of the comments I use with those patients is, there's an old joke about a fellow that says, doctor, it hurts when I do this. And the doctor says, don't do it. Everybody that's on this call, I'm sure, do that. Every mother I've said that to knows that answer. And I would bet that 3/4 of the adolescent males have no clue what I'm getting at. But the reason I bring that up here is when you're looking at depression, it's exactly the opposite. And instead of saying, if it hurts, don't do it, you say, if it helps you feel happier or better, do it. So I will say that to them. And I'll sometimes even use that joke and say, this is the opposite. Are there things that you like to do that make you happy? And unless they're severely depressed, there are usually at least 1 or 2 things that they can come up with. And again, I'll say, are you doing those? And often the answer is no. Well, what does that tell you? And it's nice for them to be able to say, gee, maybe I should do more of it. Great thought. Now, it is interesting when you do this. Sometimes, particularly those here in Minnesota, need to give our patients permission to do fun things. It's part of our heritage as a state and some of the Norwegian background going way back, and it seems to filter through to lots of folks. And sometimes if they say, I don't have time after work, and that's where I'll point out that patients who are depressed can't be as productive, and if they can treat themselves well here, they'll actually do better for the workplace. So sometimes you work it through. But again, it's letting the patient come up with the conclusions and helping the patient to decide for themselves what they'd like to try. Now, once we get past that, and that's frankly a conversation I try to have with all my depressed patients to at least some extent. Now, I've taken a long time with this. It actually takes a minute or two to go through this. And I usually just pick one of these as an action plan to start the first time. The other question that patients really have to decide is, unless it's so mild that we don't really need to move forward, patients with moderate depression, we tend to recommend, based on current guidelines, either pharmacotherapy or psychotherapy. And patients with more severe depression, we tend to recommend both. But this is one that is absolutely perfect for shared decision making, because it's like, do you want this surgery or that surgery? And giving a choice like this makes it more likely patients will, in fact, choose one or the other and then follow through. It's like when I see little kids and I'm looking in the ears and I say, which ear do you want me to look in first? And they're much happier when they get to make the choice. It gives them some control. Part of it here, and the majority of my patients probably in my experience have not wanted to go to see what many of them characterize as a shrink. They see more stigma attached by going to talking with the crazy doctor. And we have a tendency in our society, unfortunately, to think, you got a problem, you take a pill. But that can work for us here because that will tend to make patients think, well, a pill will help, which in fact many times it can. And on the other hand, I occasionally get patients who say, I don't want to take any medications, I've had bad side effects in the past, or I'm scared of medicines, or I'm already on too many, or they cost too much money. And so they would choose medication, or would choose, instead of medication, they choose to talk to a counselor. And many of them, if they're oriented this way, have already spoken with counselors about something before, so much more wanted to consider this. So what I'll do when I sit down with a patient as part of this is to say, you really have two good choices in terms of treatment for this, and both work, and they probably work about equally well. You can have medication, or you can go to talk to a counselor, or if you want, you can do both. Now, part of the benefit of medicine is it works a little bit faster overall. Part of the benefit of counseling is it tends to work longer. If you go off medicine, you don't lose the things that you get from counseling. But either one would work. Now, if you choose medicine, the one I'm going to recommend, I might say based on the protocols that Tasha was talking about, I'm going to recommend one for you called fluoxetine. That's the one you probably heard of it. Another name is Prozac, and most patients have heard this. And I pick it because it doesn't have a lot of side effects, and if you have to pay for your medications, it's now generic, so it doesn't cost as much. Side effects, there are lots of minor ones, might make you a little nauseated or a little bit lightheaded. For some people, it makes it a little bit harder for them to go to sleep. Others, it will make sleepy. If it makes you sleepy, you take it at bedtime. If it makes you awake, you take it in the morning. So those other side effects tend to go away over the course of a week or two, so if you just continue it, it will help. A few people take this and they find that they lose interest in sexual activity, but a lot of folks who are depressed don't feel like having sex because they're depressed. And so this can help, in many cases, much more than would hurt. And if it does cause that problem, we can deal with that. On the other hand, talking to a therapist, you can go to, and they can work through many things, not just your depression, but some of the other issues that you may be having, and teach you ways that you can use this for the next several years. What would you like to do? Now, part of this beforehand, I've already taken a history before this. Anybody in your family who's had depression, or have you ever had depression before? And when I get to this, that's one more point where I'll pull them in. Say, have you been depressed before? Have you been given a medicine? Did it work? If the answer is, yeah, it worked pretty well. Did you have side effects? No. That's where you start. If they haven't, but they've got a family member who's been on a medicine and did well with it, again, we'll go that way. And if that's not the case, I'll often say, is there a medicine that you've heard of that you would be interested in talking about? Because lots of them see, unfortunately, commercials on TV to push them one way or another. And if they come in and say, that stuff I saw on TV, that Sexella, Select, or something like that, that looked really good. And probably because the girl that was in the commercial was pretty. I don't know. And in that case, though, if they say, I'd like to try that, well, it depends what it is. The ones who come say, how about that Abilify stuff? Well, no, we don't start there. More often what I get is, my buddy down at the station was on that Celexa, and he did really well with it. Part of the reason we do that is, again, if they can be involved in that decision, first, there is a placebo effect. If they think it's going to work, it's more likely to work. And second, they're more likely to remain adherent with the recommendation and work through some of those minor side effects that will tend to go away. So making a partner in this decision will improve adherence and increase the likelihood of good outcomes. And I guess at this point I'd like to pass this back to Tasha because I know you got your own scripting that you use and your own ways of approach. Anything else to add?
That was actually pretty good, I have to say. I might have actually learned something today as well. But it is very true that you have to be a partner in the patient's care, and asking them what they're willing to do or what they think about things is really important. And that's true for treating any condition or leading groups of people, you know, you really have to bring them along. So what I'm going to move to, since I don't have a lot to add to that, is the psychotherapy aspect of this. And that can get very tricky for people. And so there's some things that we've been working on. And, you know, sometimes you're working with patients and you've gone down this path where Dr. Wyman has talked about, and you've talked about exercise and things like that, but you just can't quite get, and maybe they're even on medications, but you just can't quite break that barrier for patients, and that's where we get into that thought process. And we have a fabulous program called Beating the Blues that is being rolled out to all of our employees, and also it's available as a free opportunity for our patients, and it's easy to use and very simple. And the online program of Beating the Blues is a form of something called cognitive behavior therapy, and it is the only evidence-based therapy that is proven to be effective. And basically what it is it's changing the thought process about how you're looking at something. You know, you can be running late for work or a meeting and sitting in traffic, and you can make a choice at that moment. I can get really angry at the people that aren't driving fast enough, or the person that had an accident on the side of the road, or the person that has a flat tire, or I can look at this as an opportunity to breathe. I'm going to be late regardless of whether I'm angry or not. So this is, and the reason that the online therapy is good is we see patients constantly in the clinic. They maybe don't have the financial resources for therapy. They have a stigma about going to therapy. They have a hard time finding a therapist that they like. And so the online option allows them to do that on their own time, through their own resources. They just need a phone, an iPad, or a tablet, I should say, or a computer. So there's one way to do therapy. And sometimes when I ask patients, I say, you know, you have options here. You're not feeling great, medication or therapy, and you never know. I mean, I think the one thing listening to Dr. Weinman is not to approach it with judgment or make assumptions about what a patient is going to choose. Bringing them into that shared decision-making and letting them decide is really the key. So Beating the Blues is one option. And in the next slide, we didn't hit that one there. Anyway, so Beating the Blues, here's an example of what it looks like online. And is shared decision-making practical? I think that, as already pointed out, it absolutely is practical. And in the long run, it's going to save a lot of time down the road, and getting buy-in from your patients is critical. And I think that what you're going to see is you're going to see your patients with depression improve much better, but I think you're going to see some improvement in the chronic diseases around it as well. I don't have any specific studies to state about that, and I'm sure that they're out there, but I think if you have a motivated patient because they're making that choice in their care and managing their depression, you're going to see improvements in diabetes and blood pressure and weight loss, et cetera, et cetera. So getting in more depth about how we are improving therapy is patients are more apt to do therapy if we embed therapy into primary care. The primary care relationship is critical, and patients will often say they have a trust in you. And if you say, hey, you know, I have a therapist working right down the hall in this building, you know where it is, they're familiar with it, they're more apt to follow through. Plus, the therapist can be giving us feedback about how the patient's doing in an easier fashion than when they live across the city. So we are embedding therapists within primary care. We're doing that both at Park Nicollet and Health Partners, and recognizing how important this is nationally. And another way here, back to Art.
You know, and it's interesting because part of the reason that Tasha and I are moving this back and forth is our respective organizations are doing things differently. They're much further ahead in integrating the therapists into their clinics, which I think has had a lot of success. And on our side, we were part of what's called the Diamond Project, which I assume many people on this telephone call are familiar with, depression improvement across Minnesota, offering new directions. And the key there was the use of depression care managers. These are people that we have brought in, and they may be nurses, they may be social workers, they may be other folks. Their primary job is to maintain contacts between the patients and the clinicians, and between primary care and behavioral health. So if we refer somebody to a depression care manager, within a few days they'll contact the patient and say, hi, Dr. Weinman asked me to give you a call. I think he let you know I'd be calling, and I just want to touch base, see how you're doing. Were you able to get that prescription that he gave you? How are you feeling? Any problems with that? Just in general, what are you thinking about what he told you the other day? And I'll give you a call after they go through it. I'll give you a call in another week. We'll see how you're doing. They build a relationship. It builds the trust. They certainly get patient input and opinions on what they're looking for. So this is another way. They don't actually call it shared decision-making, but in fact it adheres very closely to that spirit because they're constantly getting feedback from the patients in terms of how things are going and what they would or would not want to do. The other thing they do is that they help coordinate the care between myself as a primary care clinician and our behavioral health colleagues so that if I'm not having success with a patient, I need some additional assistance or suggestions, that will come closer. Again, it's not always easy for me to get hold of a psychiatrist, and this is a great way to tap into their expertise without my having to set time aside from my schedule or his or hers to do that. Now, our problem with depression care managers is, for us at least, they're a limited resource, and they are very valuable when we use them, but we don't have enough for everybody. So we thought at first, well, why don't we just use them for all of our patients with PHQ-9 scores of 20 or above, those who are considered severe depression. And that would have worked really well if the depression care managers didn't have to sleep and there were 37 hours in a day. So we've had to limit it even further there, but we still try to choose those patients who are going to benefit the most from that. This is part of it too. And this is, again, a way to keep engaged. The biggest difficulty that I find with patients after they have the diagnosis, the biggest difficulty is actually getting in touch with them, having them come in and realizing they are depressed. But after that, the next biggest difficulty is not losing them to follow-up, because if you're depressed, it's hard to follow through with things, whether it's medication or making further appointments. And once patients don't follow through, they feel ashamed, and then they're less likely to come back. So what we have done, and even if they come back for their ankle sprain or for the cold, we don't think to ask them about their depression because they're here for my ankle hurts or sneezing and coughing. So what we have done, and again, this started first on the Park side, and they've spread it to us, just like a good disease, is that every patient who has depression on their problem list will get a PHQ-9 done at every single visit. If kind of think about what you do with patients with high blood pressure. Somebody with hypertension comes in, you will always get a blood pressure, even if their last 3 were normal. Same thing should be same here. Even if they've been doing well with their depression, we still want to make sure that they're continuing to do well. And the way that we've been able to do that in our organization is with the electronic medical record. Now, we, like most of you, have a love-hate relationship with our record, which is Epic, which is really, really good, except when it's not. But we will use that to give us best practice alerts. We will use it to tell us which patients have a history of depression. We use it to give us best practice alerts saying it's time to do something, including getting this. And when we know that we need to speak to them about depression, we can do it at that face-to-face visit, or we can call them, or we can write them a letter, or we can do it electronically through something that we've called MyChart. And part of the way we've been able to do that is through a registry. We have found, like, again, most of you probably have, that if we're doing population health work, the best way for us to keep track of patients is through a registry. So we use our registry to determine which patients need outreach based on their PHQ-9 scores and what kind of treatment. So we use the PHQ-9 as a proxy of, are they still involved with us? If we don't have one over the past 2 months, we contact them. And frankly, we can do it very quickly. At the beginning of each month now, we have one of our depression care managers batch all those people who need to have this done if they're online with our MyChart, and they send one mass email to them saying, hi, Mr. Smith, we're just checking to see how you're doing, and Mr. Smith will hopefully fill out the PHQ-9 that comes along electronically, send it back, and then we can use that to determine how aggressive do we need it to be at further follow-up. And if we don't get them that way, we'll call them. And if we don't get them that way, we'll send them a letter, and then we adjust their ongoing care plan based on that response. This is what our registry looked like. We really like it. It's so much better. It used to not be very user-friendly. The one we got was one called Reporting Workbench from Epic, which was terrible. It was just better than any other that was out there. And we've been able to modify it to this. So our nurses go on this and they look, if it's a green dot, they're up to date. If it's yellow, coming up red, you need to contact them. And it makes it very easy to use, and it's allowed us to continue to remain engaged with our patients, which again is the key to the shared decision making.
So to wrap this up, here are our take-home points. So as you've heard multiple stories, partnership is key for patients in primary care and between providers and patients, between primary care and behavioral health, and between organizations as well. Use every opportunity you have to engage patients about how they're doing. Get that PHQ-9 whenever you can so that you can have those touch bases. And patients, through feedback from our patient partners, have stated that they love the outreach. They love to know that somebody's out there that cares and is checking in on how they're doing. Behavioral activation. Get them involved in making the decision. You know, for me to tell a patient that you'll love running and it'll make you feel better when they hate it isn't going to work, but ask them what it is that they love to do. And I thought that was great about the hobbies and the things. If you love to knit and that makes you feel good, then you should knit. Knit all you want. Use your electronic medical records at the top. Make sure that it's, make it work for you. And then the other options. Discuss medications versus counseling. Do you need one? Do you need the other? Do you need both? And then if it's a time limitation or a stigma, we also have Beating the Blues. So finally, just remember, to collaborate means that success is built on relationships. And that's it.
So now I think we have a couple of minutes, and I think if anyone on the phone has some questions, we're going to go ahead and unmute the phones, and we're going to allow you to ask a question of Vicki, Art, or Tasha.
All guests have been unmuted.
So maybe we can assume that there's no questions from anyone on the phone. Okay, well, I think we'll go into our closing comments then.
All guests have been muted.
All right. So here's the contact information for Art Weinman and Tasha Gaffney. This will also be posted on the Stratus Health website. We want to call your attention to a couple of additional webinars. The next one that we're going to have is in February 2016, and Dr. Georgi Krupin from Health Partner Center for International Health will be talking about medication adherence and depression care among immigrants and refugees. So look for some information about that to come out. And then we also had our past webinar in July 2015, Cultural Awareness in Mental Health Care, and that's also posted on the Stratus Health website. And you can get CEUs if you follow this link here and then take the survey. You can access the CEUs and give us some feedback. So please remember to complete that evaluation. We will be posting the slide deck and the recording of this webinar on the Stratus Health website. And have a wonderful rest of your day. Thanks.
I'll be emailing out this link.
Oh, yeah, and this link will be emailed out to everyone that signed in as well. Thank you.
Okay.